Alright, so Pharmacist Interventions Part 9. In this video I'm going to talk about the most common prescription errors that I see and then my interventions on them. So first one I see involves nitrofurantoin, which is the most commonly prescribed antibiotic for UTIs. It's first-line therapy. It comes in 2 formulations, macrodantin, which is dosed every 6 hours, so 4 times a day, and then macrobid, which is dosed every 12 hours or twice a day. So I see a lot of practitioners sending in macrodantin and dosing it like macrobid. So they'll send in macrodantin and then dose it twice a day. So you're not really hitting that bug for that full 12 hours. You're hitting it for 6 hours with the macrodantin. 6 hours you're not hitting the bug. So it might not treat the infection if you're dosing macrodantin like macrobid. Second most common error I see is practitioners prescribing the topical metronidazole gel for vaginal usage. This is the vaginal formulation. It's for bacterial vaginosis. It's supposed to be used nightly at bedtime for 5 days. And practitioners will electronically prescribe that topical formulation. The system will input that topical formulation, and then the technicians will push it to the pharmacist because they don't know better. And then upon verification, I'll notice that it's the topical formulation and the field for the drug, and then the instructions of use vaginally for 5 days. So I will have to reject that prescription, go back, edit it, put in the vaginal formulation, and then push it through as that, because that's what was supposed to be prescribed. I've had a couple patients actually pick up the topical formulation. I think only one has used topical formulation vaginally, and I'm not sure how they did that because this one comes with applicators for usage, and the other one did not. Another common prescription error I see is practitioners sending over dual SSRI therapy or SNRI therapy inappropriately. This is usually either a different practitioner or we're switching the patient to a different one, but there aren't any notes saying discontinue the Lexapro, discontinue the Prozac, patient switching to this drug. So I had a patient a few days ago who was switched to duloxetine from Lexapro. They were already on the max dose of Lexapro, and they were also on Remeron and Trazodone. So Trazodone is an SSRI, and Remeron is not, mirtazapine is not an SSRI, but it blocks alpha-2 receptors, which is a hetero and an autoreceptor. So it increases serotonin and norepinephrine output. So it does increase serotonin. So I asked him which one he's supposed to be on. He didn't know. So I recommended stopping the Lexapro and talking to the doctor about probably he's supposed to be taking the Cymbalta as a new medication. This happens also with long-acting insulins a lot, so Basaglar, Tresiba, Levemir, I'll see dual therapy. Patients don't know better and think they're supposed to be on both of them, and there usually aren't notes saying discontinue the other insulin. So I'm going to have to sift that out with the provider to make sure that they don't overdose on their medications. Alright, so this is Pharmacist Interventions, actually part 12. I kind of lost count in there. But I had a patient who had a newly diagnosed seizure disorder, and she came from the ER and they prescribed Briviact. That medication is $1,500 for a bottle of 60. Of course it wasn't covered with insurance. It was a Medicaid patient, and ERs don't do PAs. So I recommended that they unfortunately either go back to the ER or call the hospital and have that switched to Keppra. And then they did, and then it was covered. Brivaracetam is Briviact, Keppra is levetiracetam. They're in the same drug class. Another intervention I made was I had a patient who was prescribed both carvedilol and metoprolol. He had AFib and heart failure. It's not appropriate to be on 2 beta blockers for that. He didn't know which one he was supposed to be on, so I messaged the doctor and I was like, can you clarify this? Which one are they supposed to be on? I messaged the cardiologist because I'm like, they probably have a specific one that they want the patient to be on. And I was correct. They wanted the patient on metoprolol, which I like better since it's a daily dosing. Another intervention I made is I had a female patient who's having migraines every day and who's missing work, and the only medication that she was on was as-needed Nurtec. So Nurtec is a calcitonin gene-related peptide receptor antagonist. It's one of the newer drugs like Qulipta, Ubrelvy, and it's an oral formulation of basically Aimovig, Emgality, stuff like that, and it's used as mostly treatment therapy, and some patients do use it preventatively. But per guidelines, if you're having more than or equal to 4 migraines a month, it's recommended to be on a prophylactic or preventative therapy, like something like propranolol, topiramate, valproic, something like that. But something that I like to recommend to patients is Emgality and Aimovig and Ajovy, the injectable therapies, they're monthly therapies. And some of them actually you can do 3 injections that'll last 3 months. But I've had a lot of symptom relief with patients. taking those injectable versions. And then the last intervention I want to talk about is I had a Medicaid patient prescribed hydrocortisone acetic acid for otitis externa, which is an outer ear infection. It was $160 and non-formulary for her Medicaid. So I called the hospital and I talked to a pharmacist that was actually working in the ER, and I had them switch it to what I call neopolyhydro, which is cortispor and HC Otic, and that was covered in no copay for that patient, so she was very grateful for that. All right, Pharmacist Interventions Part 12. All of these were yesterday, so yesterday was kind of wild. But I had a provider prescribe viscous lidocaine for a patient who was an infant for teething pain. The FDA recommends against prescribing this in patients less than 3, and I think even less than 12 in the European Union it's recommended against. It's a sodium channel blocker. That's how it works as a numbing agent, but it also blocks sodium channels in your heart, so it can cause cardiac arrest, and it doesn't take a lot to become toxic for patients. But we sometimes use it in the hospital for emergency like VTAC or VFib situations. I don't think I really saw it on my rotations. But it can cause seizures as well. It can oxidize iron in the blood from the ferrous to the ferric state, which can decrease the binding capacity of oxygen, so it decreases delivery to the cells. That's called methemoglobinemia, because it increases methemoglobin in the blood. Again, it has a decreased binding capacity, so that can cause like confusion, basically the symptoms of you don't have a lot of oxygen, cyanosis, stuff like that. It's a class 1B antiarrhythmic. So I recommended against that. The caregivers wanted other options. They wanted to use benzocaine. I said no, because it's in the same drug class, and I recommended ibuprofen, and then following up with the practitioner. Another interaction I had was a patient who is on isosorbide mononitrate as well as Viagra. It's contraindicated to take nitrates and phosphodiesterase 5 inhibitors due to the risk of causing potentially fatal hypotension. So it's recommended to hold your dose of isosorbide mononitrate at least 24 hours after Viagra and 48 hours after Cialis, because Cialis has a half-life of up to 17 hours. This is because nitrates can cause vasodilation, smooth muscle relaxant. That's how the long-acting nitrates like isosorbide mononitrate and dinitrate work for angina or chest pain due to like plaque buildup in the coronary artery. But again, you're not supposed to use those in combination. It's kind of like nitroglycerin, but a longer-acting nitroglycerin. The last intervention that I had was with a patient who was initiating Lamictal or lamotrigine, and they were already on Depakote. So the interaction there is you're going to have an increased effect of lamotrigine when you're taking Devalpro-X. So when you're tapering, you already need to taper Lamictal rather slowly, which ideally it's 25 milligrams for about like 2 weeks and then 50 for about 2 weeks. But the provider prescribed it as 25 per week and then 50 for a week, which is already kind of rapid, and you need to extend it even longer when you're on Depakote. So it's supposed to be 25 for like every other day for 2 weeks, and then 25 daily for 2 weeks, like that, due to the risk for toxic epidermal necrolysis as well as Stevens-Johnson syndrome, which can potentially be life-threatening, so you need to taper it very slowly, very cautiously. All right, Pharmacist Interventions Part 14. So yesterday I had a patient picking up Celexa, 40 milligrams, which is the maximum dose, or citalopram, paliperidone, 150 milligrams intramuscular injection, as well as trazodone, 200 milligrams. All three of these drugs have a warning of QT prolongation, which is a risk for palpitations and then a progression into an arrhythmia. So I asked her if she ever had an EKG, because usually a doctor will get like a baseline EKG, especially in patients who have like cardiomyopathies or any predisposition for that, but she did not have a baseline or even periodic EKGs, and she was on 3 drugs at relatively like high doses, or like medium to high doses, that would warrant EKG monitoring. So I recommended that she talk to her psychiatrist and see if they want to do that, just as like a cautionary measure, especially when you're on these medications. It's definitely something you want to monitor with patients. I had another patient who was picking up, like, I kid you not, 1,080 hydroxyzine tablets. This was for a 90-day supply, and it was 25 milligrams. So I intervened on that, and I said, hey, this medication is supposed to be used as, as needed. It's not usually supposed to be scheduled every single day, like 4 times a day, like 1 to 2 tablets 4 times a day is a lot. I've never seen anyone try to pick up that many. I had like 2 bottles of 500 and then another 80. I was like, well, there goes all my inventory. but I did intervene on that. I had another patient who was picking up 3 inhalers. He was on Trelegy, which is a triple inhaler for COPD. It's umeclidinium, vilanterol, and fluticasone, which is a long-acting muscarinic antagonist, the umeclidinium, long-acting beta agonist, and then a steroid. So usually with COPD, you treat with a LAMA and a LABA, which is the muscarinic antagonist and the beta agonist. In patients with elevated eosinophils, we add on a steroid. But he was also picking up Spiriva, which is tiotropium, and Advair, which is fluticasone salmeterol. So he is basically on like way too much. So he didn't know which one he was supposed to be on. I recommended likely being on the Trelegy and then following up with pulmonology and seeing what was going on, because it was 2 different providers sending in these inhalers. Last but not least, I had a patient picking up naproxen, which is a 2-day NSAID, and meloxicam, which is a daily NSAID, has a higher risk for cardiovascular side effects, and he didn't know which one to get, so I recommended meloxicam and not taking both. All right, so Pharmacist Interventions Part 15. Most of these are recent, like within the last week, but I had a 67-year-old female patient picking up Celexa 40 milligrams daily, Buspar or buspirone, 15 milligrams 3 times a day, Abilify 2 milligrams daily, and bupropion 200 milligrams twice a day. And was flagging for some interactions with each other. The Wellbutrin blocked the metabolism of the Abilify a little bit and the Celexa a little bit. So I was monitoring for like symptoms of too much or one or the other. I was asking about, of course, palpitations. Celexa was at its max dose, and it's actually a little higher than what's recommended for older patients. But I figured out this patient was dizzy, experienced a lot of dizziness lately. All these medications can cause that, mainly probably the Buspar and maybe some of the Wellbutrin. It's not good for an older patient to be dizzy because that poses a fall risk, and then patients, especially female patients of higher age, are at risk for fractures. So I told her to follow up with her provider about that and see if we could decrease the dose or one or the other and figure out what's making her so dizzy. Another intervention was I had a caregiver picking up a antibiotic for a 1-year-old, and it was I noticed that they picked up some recent prescriptions of both amoxicillin and Augmentin for this 1-year-old. So I stopped by and I was like, hey, what's going on? And it seemed to be either reoccurrent or an ear infection that just wasn't going away, like an acute otitis media, an inner ear infection for the 1-year-old. And I ended up counseling on what the signs of C. diff were. C. diff is a pretty dangerous infection for patients, and it's usually when you have a lot of recent broad spectrum antibiotics. So I talked to the caregiver about some fulminant diarrhea, some really profuse watery diarrhea, multiple a day. And then I also talked about possibly blood in the stool. And then I also told them that the Ceftonir could also color the stool orange. So that's what I talked to him about. I actually did have a pediatric patient, I think it was a year or 2 ago, when I was an intern, a caregiver told me that their kid actually got C. diff from something. So I thought about that when I was talking to him. Today I had a patient who's my age and she called and she said, I have a drug interaction question. And I was like, oh, excellent. I'm perfect to ask for this. And she said that she was taking Flexeril and Zoloft. And she was like, I don't know what's happening, but I'm waking up in the middle of the night. And I feel I just don't feel good. My skin's crawling and I'm sweating. And I was like, okay, well, that might be some sort of mild serotonin syndrome coming from both of those that you're taking. So she's like, well, what do? Do I space it out? And I was like, well, I know that Flexeril is usually 3 times a day. And I was like, it sounded like she was taking it twice a day. And I said, you can try taking the Flexeril at night and the Zoloft in the morning. But I said that you probably will still have some sort of side effect by taking them. Zoloft has a 26-hour half-life and it stays in the body pretty long. But I said maybe try with one. If you still have that side effect, I recommended maybe trialing tizanidine, another muscle relaxant, or asking the provider about that because it doesn't have a serotonin increasing effect. It is an alpha-2 agonist. So it's alpha-2 is a heteroreceptor. So when you have a drug acting on that receptor, it decreases the output. It's a negative feedback, so it decreases sympathetic output. The last one I wanted to talk about was I had a patient who was prescribed a lot of opioids. It was Oxy, 10 milligrams, and she was supposed to be taking 4 of them every 4 hours. And then she also got prescribed morphine 15 extended release 3 times a day and morphine 60 3 times a day extended release. And I was like, that's kind of a lot. I pulled up her inspect report to like make sure she's opioid tolerant. This is not a patient who is new to opioid therapy because I had no history on the patient. And I saw fentanyl 50 patch picked up and Oxy 30 recently picked up. I was like, oh my goodness, what is going on? So I called the hospital and I got a hold of the provider, and the provider was a little confused. She was like, what? I didn't prescribe any fentanyl. When I asked about the fentanyl, and I was like, oh, well, there's like recent history that she was on fentanyl. Like, she had no idea. And then I was also like relaying the information, like the morphine that you sent over requires a prior authorization. She's like, oh, well, how do I do that? And I was like, oh dear, you can call the inpatient pharmacy because they're going to walk you through it. They can help you. They can actually file it on your behalf. So I recommended that I have the inpatient pharmacist call me, or one of the pharmacists. So about like maybe like 20 or 30 minutes later, I got a call, and it was one of the inpatient pharmacists, and I was like talking to her. I'm like, what is up with the fentanyl patch first? And then she said, oh, that was being discontinued. We're switching her to morphine. And I was like, okay. And then I also figured out the provider meant to send in the Oxy, the 40 basically every 4 hours if needed. It wasn't supposed to be scheduled. So we canceled that prescription, had her resend the as needed one. And then I told the other pharmacist about the PA with the morphine, and she started those. There's just a lot of miscommunication with that. And the caregiver ended up coming to the pharmacy and was like, yeah, the provider said everything was ready. And I was like, it's not already. It's just the Narcan and the Oxy. There's a PA on the morphine. I told her about all that. And I asked her too about the fentanyl because I was curious, and she said that it was overly sedating the patient. And I was like, also like, what's going on with the patient? Because there wasn't a diagnosis code that came over either. And that she was telling me about the stage 4 cancer that she had. So I discussed that. I would recommend like having her like consult either pain management, an oncologist, or some sort of pharmacist within that realm about switching between the opioids to make sure that it was both an appropriate dose, like managing the pain, but also like not too much and overly sedating the patient. Because the morphine mill equivalence was like 500 to 85. That was set in for the 2 morphines and the 40 Oxy, and the Oxy 30 that was previously on, I think, was discontinued and dose increased, but it was just a lot. It had me stressed out because it was like, there was no communication with me. I had to like search for it and be like, where is this all coming from? This is kind of a lot. Like I need a diagnosis code. I need to know what's going on with this. I can't just prescribe or like allow the dispensal of all these products on my license and for the health of the patient. But we ended up kind of figuring it out, and pain management was going to take over the PA for the morphine from there. I know this is a longer Pharmacist Interventions video, but that last one I wanted to talk about a little bit. All right, so Pharmacist Interventions part 16. About a week ago, I had a lady come to consultation. It was a morning that I worked, and she said that she had like a cyst on her chest, and she's taking antibiotics for it, and she was asking me what my thoughts were on it because she said it was starting to pus and starting to smell. So I usually ask for a picture of like cellulitis or cysts or skin reactions or what have you from patients. Some pharmacists don't want to see that, but I want to see it to sort of gauge how bad it is, to see if it's infected, see if it's something that I can like probably guess, like maybe it looks like shingles, maybe it looks like eczema or something. So I was like, yeah, do you have a picture of it? And then she said no, so she went into my consultation room, my vaccine room, took a picture of it, and then came back out. And when I tell you this is the worst like wound like I've ever seen, this is like one of the worst wounds I've ever seen. I had no idea really what it was, but it was like right here, and it was like about the size of like your hand. It was huge, and it looked really bad. It like, I had no idea what it was. It was like a tumor or a cyst or something. And I asked her what antibiotic she was on. She said like Keflex, and I was like, you're only on Keflex for that? And she'd been on it for a few days, and then it started pussing and smelling really bad. I'm like, you need to go to the ER like right now. So she did. It was like across the street, and I was like, I don't know what that is or what's going on, but they need to culture that and get you on like some probably broader antibiotics. And my technician said that she came in a few days ago and said that I saved her life. So I had no idea really what it was, what happened, because I didn't get to talk to her. But whatever it was, it either had to be removed or she might have had like a bloodstream infection or something from it. So I have no idea what it was. I'll see if she comes in again and I'll see if I can get more information out of it. But I was just appalled. And I was glad that she reported back and that she got some care for it. Another intervention that I did was I had a patient, an older woman. She's picking up Lipitor 80, and it flagged that she picked up like some Crestor a little bit ago. So 80 is the max dose for Lipitor, and it was flagging it's a 40 milligram Crestor, which is also the max dose. So I figured out that she was taking both of them, which is just a recipe for disaster. So I told her that she needs to stop one of them and then also call her doctor. See if they need to take like a CPK or see if she's having any like side effects from that. It didn't seem that she was having any really side effects, but I wanted her to follow up with her provider to see if she could get some labs drawn to see, because if you take like too much of a statin, you can get some muscle breakdown, and you can see that in the labs. It can also cause some pain too for patients, and if at worst it can cause some kidney failure, rhabdomyolysis. But my last intervention, I had a patient who's on hormonal replacement therapy, estradiol. It was 2 milligrams sublingually twice a day. Patient ran out of refills, so I allowed an emergency fill. So for maintenance medications in Indiana, we can allow up to 1 month supply of an emergency fill, where we don't need a prescription for it, basically, if they're out of their prescription or it expires or some sort of issue. But I had that patient follow up with their provider within the next 2 days to get another prescription for that. And then I also updated her pronouns in the profile because it wasn't updated. So those are two things that I did for that patient. All right, Pharmacist Interventions Part 17. 3 of these were from today, and then 1 of these was from yesterday. So yesterday I had a patient picking up Lamictal 150 milligrams, and I didn't see any recent history of like a titration up, because you need to titrate that medication up over a few weeks. Again, Stevens-Johnson syndrome, most patients know. He said his last dose was in April. He was on it in the past, he stopped taking it, and then he went to the ER and was having seizures, I guess, and then they just started him at 150. So I told him he needs to retaper that. He can't just start at his last dose, again, due to Stevens-Johnson syndrome. Today I had a patient who's prescribed metformin, and the directions were take 500 milligrams on day 1, which is 1 tablet. On day 2, take 500 twice a day. On day 3, take 1,000 in the morning and 500 in the evening. And day 4, take 1,000 in the morning and 1,000 in the evening. Metformin needs to be tapered. You increase the dose by 500 milligrams every week. So they maxed them out after 4 days. So I'm assuming some GI upset, nausea, diarrhea with that. I put a forced note on it to counsel him at the register. The system did not flag that, but I caught it because I thought it was weird when I was entering the instructions, and I was like, oh, this is tapered incorrectly. It's supposed to be 500 daily for a week, and then you increase to 1,000 as the patient's tolerating it, and then go on from there. But I'm going to talk to him later this week once I see him pick it up. I had a patient picking up, I think it's called Zelstarime or something. I don't know how to pronounce it, but it's a dextroamphetamine, like extended release patch. And it was flagging against Vyvanse. She discontinued the Vyvanse. But then I also saw we were in process with the Wellbutrin. So both of those are DNRIs, basically, increased dopamine and norepinephrine. So I asked if she's on both. She said yes. I said, okay, we'll just monitor for side effects of just too much norepinephrine or dopamine. Like if you're having like headaches, insomnia, dry mouth, stuff like that, anxiety. And she was like, I'm glad that you said something, because I've been having like headaches like nonstop, like for like a while. So I thought that was interesting. And I was like, well, it's probably the Wellbutrin that's causing these. And she said, yeah, yesterday I just had a really, really bad one that just didn't go away. And I said, okay, follow up with your provider to go from there and maybe decrease your dose or taper off of it. You can't just stop taking it. So she's going to follow up with her provider. And then the last one for today, I had a patient who's on Cymbalta. Her dose is 30 milligrams, and her provider sent in 60. It looked like they sent it in twice. So I had 2 60 milligrams on hold, no 30s. And I don't know what was really going on with the provider, but they were very non-responsive. Patient was like, I'm not on 60, I'm on 30, I don't want to increase my dose. Like, what do I do? So I recommended basically off-label to split the capsules. So to open them up, and split them. The manufacturer will tell you you cannot do this, but you can. You can open up duloxetine capsules and you can put it on applesauce. It's an enteric coated capsule that has a delayed release mechanism, so you cannot chew it, of course, and you can't sort of harm that enteric coating on it. And then another stability issue is you can't put it on chocolate pudding. So I told her you can't put it on that, you have to put it on applesauce specifically. But I did recommend that because I did not want the patient to go through the withdrawals of an SNRI. That's no fun. But those were my interventions for today and yesterday, I guess. All right, so Pharmacist Interventions Part 18. So today I had a patient who's prescribed a Flovent inhaler, and he was kind of older. So I always like to ask like what your diagnosis is, because usually they will prescribe like steroid inhalers for patients with asthma. I'm not saying that older patients can't have asthma, but they usually have COPD. And this patient did have COPD. He wasn't on any other inhalers, and I talked to him about how he needs to follow up with a pulmonologist. He said that they already recommended that. The prescription was from a resident physician from the hospital across the street, and I recommended, of course, following up with the pulmonologist, because usually you don't give like a COPD patient like an inhaler that is usually used for like asthmatic patients, steroid inhaler. We'll use steroids sometimes in COPD patients if their eosinophils are elevated, but based off of what type of COPD they have via the GOLD guidelines, we usually give them like a LAMA-LABA combo, like a Noro, a long-acting muscarinic antagonist and a long-acting beta agonist. That's usually what most patients are on, because steroids can increase the risk for pneumonia. So we don't usually give those like first line for COPD patients. Another intervention that I've had recently was a patient on a Totolac as well as Celebrex. So they're on two different NSAIDs. We have a non-selective COX inhibitor and then a COX-2 selective inhibitor. Celebrex is usually used for like osteoarthritis and stuff. But I figured out it was two different providers prescribing it, and I think the patient was like taking both of them for like a short amount of time. But they didn't know that they were like in the same drug class. You're not supposed to be on two NSAIDs. That's very bad, of course, with the warnings of renal or kidney problems, ulcers, cardiovascular risks, stuff like that. I had another patient who's picking up Lipitor 80 milligrams, and it was flagging against his Genvoya. He's taking Genvoya for HIV, inhibits the metabolism of atorvastatin, and he was plopped on the max dose. He was previously on 40, which also was too much. Usually if you're on like a concomitant enzyme inhibitor, you want to be on maybe 20 milligrams max. So I counseled him on like muscle pain. I told him that I wasn't recommended. I sent a fax to the provider and recommending like a CPK, like a lab, to see like is it breaking down his muscle, because he was already on like twice the maximum dose that was recommended for someone who's on Genvoya. Another pharmacist intervention, I had a patient who had some really bad dry mouth, and I figured out it was their dicyclamine that was causing it, antimuscarinic. And then lastly, another intervention or like I guess discussion I've had with a patient is a patient who is on two antimuscarinics for some reason, dicyclamine and hyoscine. So I counseled on duplicate like antimuscarinic therapy, like confusion, like maybe sort of dry mouth, constipation, and urinary retention. He also had a diagnosis of BPH, or benign prostatic hyperplasia. So the duplicate, or I guess dual antimuscarinic medication therapy is probably not the best for someone who has urinary retention. All right, so Pharmacist Interventions Part 19. So I had a prescription sent over for a hospice patient. It was morphine 20 milligrams per 5 mils, and the dose was 1.3 mils every 4 hours as needed for shortness of breath. So morphine is used for air hunger and pain and end-of-life care. It was for a patient that was in her 90s. So the dose for this prescription I thought was too low. If you calculate it, it's about 5.2 milligrams of morphine. Which, if you're familiar with like hydrocodone, is almost about like 5 milligrams of hydro. Hydro is a little more potent than morphine, so that's not a lot. So I thought that they sent it in the prescription wrong, and it was supposed to be the 100 per 5 concentration, which is like a pretty concentrated version of morphine. So if it were actually the 100 per 5, it would have been 26 milligrams if we were going with that 1.3 mils. So I talked to one of the hospice nurses, and they're like, no, it's supposed to be the 20 milligrams per 5 mils. That's correct. It's supposed to be 5.2 milligrams. And like, I was like on the phone, like, are you sure? Like, I was explaining the difference between the 20 milligram per 5 mils and the 100 milligram per 5 mils. And she was like adamant, like, yep, that's what we meant to send over. So I okayed the order. So come like 2 or 3 weeks later, the prescription came through like for the 3rd or 4th time in our pharmacy, and then one of the night pharmacists caught it. too, and then also called on it, and then spoke to someone else, and then they said that that was a medication error. So it was actually supposed to be the 100 milligram per 5 mil. So the patient was receiving a 5 times lower dose than they should have gotten. And then I looked at the history of the prescription. It was sent in by 3 different physicians, one being like an end-of-life care specialist or hospice specialist. So that was one like medication error that I thought of that should have been fixed when I caught it the first time. But this patient was receiving the wrong dose like 4 times, which is not good. I noticed that the patient was also like early filling it too. So that was also like a red flag of this dose is probably not correct. Another pharmacist intervention is I had a patient who was on like a higher dose of hydrochlorothiazide, and she told me that she kept going to the hospital for hypokalemia, like low potassium levels, and she kept having like heart fluttering symptoms, and she's getting like a potassium supplement. So I just recommended maybe talking to a doctor about switching to a calcium channel blocker like amlodipine. It's another first line option for hypertension or high blood pressure. And it doesn't waste potassium. It's not a diuretic. Another intervention I had is a patient who was on Pulmicort 90, and he was experiencing a lot of wheezing, basically uncontrolled asthma. So I recommended talking to the doctor about either increasing the Pulmicort, or actually I wanted him to switch to Symbicort. I thought that was a better option, especially if you're symptomatic, like on your ICS or inhaled corticosteroid. So Symbicort is recommended. Virginia guidelines is like as needed, and then also maintenance therapy. It's called SMART therapy, single maintenance and rescue therapy. Then the last intervention I had was a patient who was picking up Synjardy, metformin, and Jardiance. Synjardy is a branded combo pill of metformin and Jardiance, or empagliflozin. So when patients get prescribed things, they don't really know that they're supposed to stop what they used to be on. Like there's some sort of like gap in communication that I see a lot of the times, where when patients are switched to dual pills or the doses are changed, they just keep taking what they have already been taking and then the new medication they start taking. So I told the patient, yeah, you're not supposed to be on the metformin and the Jardiance anymore. I'm like sure that your provider is switching you to Synjardy, one dual pill, for convenience, because he thought he was supposed to take all 3. All right, so pharmacist interventions part 20. First off, I had a patient who's picking up Seroquel 200 milligrams for sleep, and then he also reported a diagnosis of restless legs, and he was on ropinirole. So what do we have? We have Seroquel, a dopamine blocker, and ropinirole, a dopamine agonist, or a drug that acts like dopamine on the receptor. So first off, it's inappropriate to use antipsychotics for solely insomnia without concomitant diagnosis of bipolar and schizophrenia, especially at that dose. 25 milligrams might be appropriate for some patients, maybe like 3rd line or 4th line for insomnia, but it's not appropriate 1st line. He didn't report any diagnosis of schizophrenia or bipolar, and the 200 milligrams is nearing that dosage. I had that discussion with that patient, and then I also mentioned that antipsychotics can cause movement problems. So sometimes those movement problems can be misdiagnosed as something like restless legs. So I said that he should probably follow up with his practitioner about that, make sure that they're aware that he's on an antipsychotic. So antipsychotics have a black box warning of increased mortality in elderly patients with dementia-related psychosis, and then it also has a black box warnings of increased risk of suicidality, particularly in patients who are children, adolescents, and young adults. So those are concerning. This is why we don't really like to use it. First line for a lot of conditions that don't really require it. I will also mention EPS, or extrapyramidal side effects. This is like your movement problems. And tardive dyskinesia, usually with long-term usage. This may or may not go away with discontinuation of the medication. It's a dopamine blocker, so of course that drug-induced Parkinsonism, that's where that activity comes from. Akathisia is something to worry about too. This is internal restlessness. It doesn't really go away. Some medications are worse than others, like Abilify, Rexulti, and maybe Vraylar. Also, you get a bunch of metabolic side effects like increased blood glucose, diabetes risk, weight gain, increased cholesterol, increased triglycerides, appetite, stuff like that. Medications like Seroquel and Zyprexa are a higher risk for that in particular. And then there's a risk of QT prolongation and seizures also with some antipsychotics. And then also something that's not talked about is drug-induced anhedonia, or lack of pleasure. This is namely for higher doses. Another pharmacist intervention is I had a patient or a caregiver picking up penicillin for his wife, and it flagged for a penicillin allergy, and I asked him, oh, does she have any allergies? Is she allergic to anything? He said, no, she doesn't have any allergies. So I was like, okay. And then I ended up calling her, and she said, yeah, I am anaphylactic to penicillin. And I was like, okay, don't take the penicillin. I don't know if I should have trusted the husband with that, but I did. So she ended up not taking it, and then I faxed the doctor about the allergy and to switch it to another medication. It was for an abscess. Another pharmacist intervention, I had an elderly patient, or I don't know what you classify as elderly, but I would say 65 and older is kind of like getting there to where you need to start like adjusting medications and doses. But I had a patient, she's in her late 60s, she's picking up Xanax for the first time, and she was given 60 tablets, so she was automatically scheduled on it twice a day for anxiety. So I had the benzo discussion with her. I talked about poor efficacy for anxiety long-term with scheduled benzo usage. Talked about cognitive decline and then also risk of dementia with continued long-term usage. I talked about tolerance, and I talked about abuse potential and withdrawal with benzos. And then I also talked about the risk of falls and dizziness, particularly in older patients. So, older patients, you don't really want on benzos or like Z drugs or anything like that. That'll make them like dizzy or have a tendency to accumulate if their renal function or kidney function is declining because they're going to fall and break a bone. That increases the risk for mortality. And then last but not least, I had a patient today actually pick up warfarin 5 milligrams, and it was flagging against Lovenox. So I assumed it was a bridge. A bridge meaning like it takes about 5 days for warfarin to become effective. Like if you have surgery, they'll take patients off of the warfarin and then bridge them with Lovenox. So we'll have like when they're coming back on the blood thinner, they'll have the Lovenox in their system like working as the anticoagulant or the blood thinner. And then we'll have the warfarin on top, and then we'll discontinue, like we'll stop the Lovenox about like 5 days in, because that's about when that warfarin's effective. So I noticed that the Lovenox was a treatment dose, and it wasn't a preventative dose. I didn't have a diagnosis for a blood clot on file. All I had was that the patient had a prosthetic valve, and the patient reported AFib as well. And I noticed the patient had been on the Lovenox for a few weeks at that point, and then was also on the warfarin. So I pointed that out, and the patient wasn't really responsive to what I was saying. She didn't like that I was questioning her medications, and she was a poor historian as well. I saw that she was also on amiodarone potentially, which is a rhythm control medication. It's for AFib. Not all AFib patients need rhythm control. They need rate control like a beta blocker, but not all patients need rhythm control. But the amiodarone also interacts with the warfarin. It's part of the Fab4 is what we call it. So fluconazole, amiodarone, Bactrim, and Flagyl, those are the 4 that are 2C9 inhibitors that can increase the concentrations of the warfarin and increase the risk for bleeds. So not only was she on the treatment dose of the Lovenox and on 2 blood thinners and then on something that interacted, that was very concerning for me. So I ended up calling the office, and I was on hold for like 20 minutes with a representative, and then I asked like a couple times, like, can I talk to the provider directly? Talk to the provider directly, and they said no, basically leave a message. So I left a message, so I'm hoping for them to call me back at some point.